morning. So today I'm talking about vitamin D physiology. So I'll start by defining vitamin D. So vitamin D is a generic term referring to a group of lipid-soluble compounds which play an important role in calcium homeostasis. The key compounds include calcidiol, which is a major circulating form, calcitriol, which is the most potent form, and cholecalciferol, which is the most common supplementary form. They each contain a 4-ring cholesterol backbone, and it makes up one of the 4 fat-soluble vitamins. So the sources of vitamin D, these include foods. Foods are naturally occurring vitamin D in foods is not a particularly prominent source of vitamin D. You can get vitamin D from food fortification, so in cereals, milk, breakfast bars and the like. But the most sort of important form is dermal synthesis, and that accounts for roughly 70% of vitamin D intake. And you can also, of course, supplement vitamin D pharmacologically. So I'll talk now about vitamin D synthesis. So pre-vitamin, you can obviously see the flow diagram there on the right. So pre-vitamin D3 is converted to cholecalciferol in the dermis of the skin. This is mediated by UVB light exposure. It's a thermal dependent rearrangement reaction. And then cholecalciferol and ergocalciferol undergo a series of hydroxylation reactions in the liver to form calcidiol initially, which is that common circulating form, and then to the kidneys to produce calcitriol, which is the most active metabolite. So the key functions of vitamin D, so calcitriol, which is the sort of endpoint of vitamin D synthesis, is the most potent form and has kind of 4 major functions. The first is to promote intestinal absorption of dietary calcium and phosphate. And this is a really important function, limiting calcium and phosphate excretion by the kidneys and direct suppression of parathyroid hormone and increased osteoblastic rankle expression to increased osteoclastic activity. So where does it fit in the overall kind of calcium phosphate kind of pattern? So you get a fall in serum calcium, which triggers a PTH release from the parathyroid cells of the parathyroid. And then the PTH initiates calcitriol synthesis, which sort of triggers renal calcium reuptake and stimulates bone resorption to release calcium and phosphate from bone. And the rising calcium stimulates calcitonin release, and then calcitonin and raised calcitriol suppress ongoing PTH release. So this is the negative feedback mechanism in the sort of calcium phosphate homeostasis pattern. So how do we monitor for vitamin D? So serum calcidiol, which is the most commonly circulating form, is the measured form of vitamin D. There are a variety of kind of definitions. I think the most kind of prominent one in the literature seems to be the American Geriatric Society. And they classify anything greater than 50 nanomoles as normal. Anything between 30 and 50 nanomoles is considered vitamin D insufficient, and these people may require oral cholecalciferol supplementation. And then anything less than 30 is considered vitamin D deficient. And these people will require monitoring of calcium and phosphate, ALP and PTH, and potentially tissue transglutaminase workup for celiac disease. And these people will require supplementation to sort of normalise those levels. So what are the causes of vitamin D deficiency? Well, there are a lot of them. These are sort of the most prominent ones, I guess. So deficient intake and absorption. So obviously low dietary intake, and this is probably something that's more relevant to perhaps under-resourced countries or areas, and particularly amongst children, but also in the elderly population who are not getting enough dietary intake. Malabsorption syndromes such as celiac disease, gastric bypass surgery, and pancreatic insufficiency, which can impair your ability to absorb fat-soluble vitamins. Decreased skin synthesis, again, this is quite a big one. So inadequate sun exposure, that's a common cause, again, amongst kind of elderly people who are perhaps sort of spending more time inside than others. And darkly pigmented skinned individuals generally don't synthesize quite as much vitamin D as others. So loss of vitamin D binding protein, so that's the protein that's responsible for transporting vitamin D. If you're losing that through pathology such as nephrotic syndrome, you can have a reduction in your sort of total vitamin D. And defective hydroxylation reaction, so that conversion from calcidiol to calcitriol in the kidneys, and also the reactions that occur in the liver. If you've got problems with either of those, you can have a reduction in your vitamin D. And certain medications such as phenytoin, phenobarbital, glucocorticoids, there's a long list, but they're kind of the more common ones which can affect your metabolism of vitamin D. So what are the consequences of prolonged vitamin D deficiency? A sort of chronic reduction in vitamin D can lead to reduced intestinal absorption of calcium and phosphate. This can result in hypocalcemia and low calcitriol, which lead to sort of a disinhibited PTH release. Chronically elevated PTH results in progressive bone demineralization, and that's kind of the critical step, which can ultimately lead to osteomalacia and rickets, which I'll talk to now. So osteomalacia and rickets are two diseases which kind of have a similar etiology, although osteomalacia is reserved for those who are post-physeal closure, and vitamin D deficient rickets is in children pre-physeal closure, and they kind of present differently. So it's caused by they are both caused by chronic long-standing vitamin D deficiency and a secondary hyperparathyroidism, which results in progressive bone demineralization and hypophosphatemia, as the bread of phosphate is excreted renally. Undermineralized bone is soft, mechanically weak, and is subject to fracture. So I'll just talk to some of the clinical features now of rickets. So rickets is thankfully an uncommon disease, although it's sort of in certain under-resourced areas is still very relevant, so it's important that we're aware of it. So you can result in sort of globally delayed development, muscle hypotonia. You can have some tibial bowing, which you can appreciate there in the X-ray. Swelling of the costochondral junctions, and I think this is sort of a pathognomonic sign referred to as the rachitic rosary, which you can see there. Craniotabes, which is unossified areas of bone which yields to kind of thumb pressure. Frontal and parietal bossing, which you can appreciate at the top right. And delayed anterior fontanelle closure and a series of dental abnormalities. So osteomalacia, this is sort of post-physeal closure. So this can result in generalized bone and muscle pain, fractures of long bones, proximal muscle weakness, fatigue, a sort of waddling type gait, and increased reuptake in bone activity on a bone scan. So how do we treat this? So vitamin D supplementation is one sort of, is the most obvious way, and the recommended daily intake is 600 to 800 international units daily for adults, and it's generally given alongside supplementary calcium. So supplementation of vitamin D is indicated for vitamin D deficient individuals with or without elevated serum PTH, but the evidence is a little less clear for those who are between sort of 30 and 50 nanomoles with normal serum PTH, and it kind of depends a bit on the clinician and the situation, I guess, and the patient. The dosing, so this is just pulled from UpToDate. They suggest that those who are vitamin D deficient get 50,000 units per oral for 6 to 8 weeks, and then 800 units thereafter. And for the insufficient or the 30 to 50 group, they typically get 800 units per oral daily, with a view to kind of reassessing it at 3 months to sort of evaluate the response. So just a brief slide, I thought about vitamin D and its role in osteoporosis. So osteoporosis is characterised by reduced bone mass with normal bone mineral to bone matrix ratio, as opposed to osteomalacia, which you get a reduction in that ratio through the demineralization. Evidence suggests that vitamin D and calcium supplementation can prevent bone loss and improve bone density in osteoporotic patients, and it's considered sort of part of the first-line treatment. Although evidence that it reduces osteoporotic fractures is more variable and depends on the population. I thought this was interesting. The benefit of calcium vitamin D supplementation in reducing fractures appears to be greater amongst institutionalised or hospitalised individuals than those who reside in the community. And it should always be given alongside denosumab or bisphosphonates to prevent hypocalcemia. And the dose is typically 20 to 25,000 units for 4 weeks. So in summary, vitamin D is an important regulator of calcium homeostasis. Calcitriol is the active metabolite and the most potent form. Dermal synthesis is the most important source under normal circumstances. Chronic low vitamin D can result in reduced intestinal calcium absorption and increased PTH release and subsequent bone demineralization. It is important to monitor vitamin D levels in high-risk individuals, and vitamin D and calcium supplementation can be given to correct serum vitamin D levels if necessary. These are here are my references.